Okay, good afternoon to everybody. I am Antonio Colombo from Milano, Italy, and I have the privilege to introduce this session about Sirolimus-coated balloons. The first presentation is going to be by Alok Finn from the United States. He will talk about a close look about the safety and efficacy from preclinical data.
Okay, thank you, Antonio, for the nice introduction. I'm going to talk a little bit about the safety of the concept MagicTouch balloon and some of the preclinical studies we've done on this balloon. Here are my disclosures. I think as physicians, we tend to think about things in the clinical arena and think about, well, that's what really matters, but actually the preclinical arena is the starting stage for every single technology that you have in your armamentarium in the interventional lab. Preclinical studies allow us to understand at the histologic level the reaction to interventional devices, including DCBs, and they're required by US FDA, by multiple regulatory bodies before human use, often reveal vascular responses to devices using techniques and methods that we really can't get in the clinic. You can get a close look at what's happening for a technology in a way that you'll never be able to evaluate in the clinic. In the end, every device we use must be evaluated for its efficacy and the safety. But establishing safety is really the job of preclinical studies. It's not so much to establish efficacy, because animal models don't have disease. It's impossible to replicate what human disease is like. So DCBs, as you know, should have their intended local arterial effect, but they also shed particulates. All DCBs shed particulates, and these need to be evaluated very carefully. Non-target organs, that is, organs that are not the intended recipient of the device, should be evaluated and maybe of special interest depending on the treatment location. So it's important at the basic level for interventionalists and cardiologists to understand the difference between a drug-eluting stent and a drug-coated balloon. Remember, a drug-eluting stent is a permanent implant. The drug and the polymer sit there for the life of the patient, and the drug is eluted from the polymer over time, and you really have good diffusion of drug. You have a real advantage when you have a metallic scaffold, obviously. The DCB is just a drug delivery vehicle. All it's doing is taking the DCB to the location, and in that 30 seconds or a minute or 2 minutes, you basically inflate the DCB and you hope all that drug transfers at that time. Unfortunately, the reality is not that simple. You can see that for paclitaxel-coated DCBs, the preferred formulation is crystalline, and that's because really the retention time of crystalline paclitaxel is better than that of the amorphous form, and that really allows us to form a depot over time, which allows paclitaxel to be in the arterial wall for longer periods of time. But like any crystalline forms of anything will shatter when they're blown up. And so when you blow up the balloon, you can see the flaking that occurs here in the Braun sequent balloon or Invitec balloon. You can see there are particulates generated. This is what I mean by particulates. These are particulates generated by just inflating the balloon. So you're not going to get all of those particulates to transfer to the arterial wall. Probably you're going to get 10 to 15% successful transfer, and you're going to lose a lot of those particulates into the body. And this has been shown in many studies, but this is just one example of how much is lost during passage of a balloon into at the target site. You can see a fair amount is just lost into the bloodstream, into the body. Histologic analysis allows us to really determine non-target organs. This particular situation is for the porcine coronary, where you can sample different areas of downstream myocardium to look for emboli and injury from those particulates. This is very important for passage through preclinical studies in FDA. They're very interested in looking at not only the target artery, but the non-target organ. In this case, it's the heart, but it could be the skeletal muscle. It depends what the indication for the balloon is. And you can see here in a paper we published just recently, this was the Prevail balloon. You can see in this particular paper we did a coronary angioplasty with a DCB, and we compared different balloons. I'm not going to go into the details of the study, but just to show you, the paclitaxel-coated DCB is a commercially available paclitaxel-coated DCB available in Europe, not in the United States. But you can see there was injury and necrosis and scarring formed in the myocardium downstream when the paclitaxel DCB was used. That distinguished it from just a plain old balloon angioplasty and from this dual API DCB that was tried in this study, but just showing you that this injury does occur and it's correlated with multiple embolic events. You can see the paclitaxel DCB had the most amount of emboli as compared to the other DCBs tried in this study. So it's well known that paclitaxel can cause embolic debris. And these are what you look for when you look for debris. You basically look at the myocardium and you look at areas of scarring or infarction, or you can see areas where, around arterioles especially, where inflammation collects. And it's very likely in those arterioles you'll find some small particulate that have embolized into the downstream myocardium in this situation, just showing you different examples of the histopathology. So this is really how it's done. Now, embolization in the clinic, does it matter? There's a big debate. I think for the most part, we really don't want embolization. If we could have our choice, we wouldn't want the drug-coated constituents to embolize in the downstream tissues. We want to go to the target and not have any loss into untarget areas. These are areas, examples of slow flow after paclitaxel-coated balloon angioplasty, as well as after drug-coated balloons looking at microvascular flow reserve. And you can see that this may be especially important in certain tissue beds. For instance, BTK. No drug-coated balloons are approved for treatment of BTK lesions at this point in the US and I believe in Europe. And the problem is that the wound healing is really impaired when you get slow flow. So when you get slow flow, you get worse wound healing and the amputation-free rate goes down. So you cannot really afford to have so much particulate generation. And the MagicTouch here we're talking about, that is a new solution. It's basically a sirolimus-coated balloon where the sirolimus is encoded in submicron phospholipid particles. And these particles are fairly small size. They're allowed to pass through. These are not particulates that are generated with crystallization, for instance. We're talking about just submicron versions of the sirolimus that are sprayed onto the balloon coating. And this is how it's done. You basically have a submicron phospholipid carrier where the sirolimus is put in the center of that carrier, and that's coated, spray coated right onto the balloon. And just to give you an example, we talked about non-target organs. We compared different balloons in a head-to-head study in the porcine coronary versus we used a POBA in some arteries. We used a MagicTouch sirolimus-coated balloon. We used a solution, which is another sirolimus-coated balloon. And we used the traditional paclitaxel DCB. This time it was Agent, which was just approved in the United States. We did follow-up angiography at 28 days and sacrifice of the animals and looked at the downstream histology. And you can see, similar to what I told you before, this time with Agent, the paclitaxel-coated balloon was the only balloon, DCB, that caused myocyte necrosis and scarring. And it was correlated with the most amount of downstream emboli. Solution was next, and MagicTouch was next. And of course, POBA, which doesn't really have coating, was the least amount of emboli. And this is just an example of what this histopathology looks like. You can see the scarring there in C and D, area of fibrosis in the myocardium. You can see small emboli, especially for the paclitaxel-coated balloon, although they were detectable with all drug-coated balloons. And I just speak quickly to a study that was done with Agent and showed the opposite result in your intervention. This was done in the rabbit model. This is a different model. And in this particular study, they didn't show any emboli with Agent. But I would say that most of the times we've studied paclitaxel-coated balloons, we've studied a lot of them, we almost always see emboli. So it's also a matter of who's looking and how many muscle beds are you detecting. And the details are very important in these type of studies. So in conclusion, I think I've shown you paclitaxel DCBs are composed of crystalline paclitaxel, which is efficacious. I'm not denying it works, but I also would like you to understand a little bit about the particulate generation. And both studies I showed you, particulates were generated with paclitaxel DCBs, they're commercially available, and resulted in downstream injury and embolic debris. And it's hard, this type of injury, I'm always asked, what does this mean in the clinic? Well, certainly it means something in the clinic. It's hard to believe that these are normal coronaries and you're getting this kind of debris. What happens in humans? It's important to at least understand, if you're an interventionalist, this type of potential for injury. And the MagicTouch SCB performed very well with less downstream emboli and more favorable profile with the myocyte necrosis and injury just seen in the paclitaxel-coated DCB. So I think these studies really do support the safety of sirolimus-coated DCBs over their currently available paclitaxel DCBs. And I think it does show that MagicTouch will play an important role in coronary and peripheral applications going forward with US IDE trials. This is one reason why they have so many trials underway. So with that, thank you for your attention.
Thank you very much. I think we have 3 minutes for questions.
I have a question.
Very short and very short answer.
Short question. What you showed us was the downstream effect. What's going on in the vessel wall when you are blowing up the balloon, and what's happening to some of the crystalline that is staying there? Is there also inflammation into the vessel wall?
There is some inflammation. There's some fibrin formation, but there's not a lot of inflammation. The issue with the paclitaxel versus sirolimus, I didn't have time to go over the whole study, I'm sorry, is that really the differential effect is in the media. You really see with paclitaxel loss of medial muscle cells, and you see replacement with proteoglycan. So you're doing some destruction of the media, and Alex can speak to this. This is why you see positive remodeling with paclitaxel. You see dilatation, and it's not dilatation that's compensatory, it's dilatation from the media being injured, and the vessel dilates. You don't see that with sirolimus. We don't, I didn't show you all the details, but we've got detailed histologic information. You don't see that with sirolimus. So I think it's one advantage, Roxana, of these sirolimus-coated balloons. The cytotoxicity is just simply not there. Is it fair to compare late loss when a balloon has negative late loss to one that has some late loss? Does it mean it's not as good? I think we're beginning to understand that these are unfair comparisons. What really matters is the clinical data.
I want to ask a quick question to Marie-Claude. Why this phenomenon seems to be real? Why we don't have any study? Why no company, at least selling Limus, did a study to show the advantage versus clinical study versus paclitaxel?
There were studies versus paclitaxel with surrogate endpoints, angiographic, but clinical, no.
But they are surrogate endpoints.
Yeah, with surrogate endpoint. But I understand now that this enlargement is due to toxicity, but in clinically it can be interesting because you never get with a balloon the same acute gain than with a stent. So this positive remodeling can be good clinically.
Is that positive clinically, or maybe is a toxic effect? Because maybe the vessel wall is not healthy as it should.
With paclitaxel.
Yeah.
Well, I think that speaks to the function of the media, which is contraction. And so, you want vasodilatation. When you exercise, your artery vasodilates. The muscle cells relax. They accommodate to the demand of the myocardium. So I think vasodilation and contraction, they're all important in terms of normal physiologic response. Do we know the responses are normal after paclitaxel-coated balloons? We don't really have that information.
No. Okay. Thank you very much. Thank you very much. I think we go to a clinical presentation now, MagicTouch data in real-world population, Sandeep Basavarajan.
Thank you so much, Dr. Colombo. Good afternoon, everyone. So my task is to kind of show some real-world data from 4 centers we've been working on the registry, and also show some complex cases where we have used MagicTouch drug-coated balloons. So this is the study we kind of from 2016 to 2022. So 4 centers, 3 Italian and 1 UK. 3 Italian obviously is from Colombo's group, and then Luca Testa from Naples. So the general indication for DCB in all these centers are obviously ISR, small vessels, long lesions, side branches, especially in true bifurcations where you won't avoid a stent, and of course patients high bleeding risk who cannot take DAPT beyond a month. So in this period we had around 1,360 patients treated with MagicTouch, of which I'm just going to focus mainly on the de novo lesions, which is obviously interest in the current era. So 771 patients, and the mean age was 68. I'll just highlight some important demographics. So obviously diabetes is obviously the one of the main indications. You could see it's almost 36% of patients were diabetic, of which 14% were on insulin. And CKD accounted for 15% of these patients, and you could see almost more than half of these patients were in the setting of acute coronary syndrome. And atrial fibrillation was also seen in around 9%, so which means these patients were on DOAC or warfarin. STEMI accounted for around 7% of the population. Procedural characteristics, as you could see, these are all generally small vessels. Almost 80% of them are less than 3 millimeter, and again, more than 20 millimeter of the lesions accounted for almost 75% of the cases. Pre-dilatation in the initial phase was not 100%, should have been, but in the later stage it's almost 100%. So obviously this relates to the learning curve of the operators and the unit. Most of the lesions were treated with semi-compliant and non-compliant balloon, but we had to use scoring balloon in 23% of cases because other vessel recoils are not yielding. And again, small proportion received cutting balloon and rotational atherectomy. In terms of further vessel characteristics, most of them were in the LAD diagonal bifurcation and then followed by circumflex and right coronary artery. Small proportion of these patients were in vein graft and left main. Bifurcation lesion accounted for 34% of these cases, and intravascular imaging was done in 21% of the cases. So bailout stenting, defined as using a stent post-DCB, was seen in around 9%, which is a small number actually, compared to previous studies where it's been up to 20% in de novo lesions. So again, as I said, these are small vessels, so mean diameter of the DCB use was 2.6 and the mean length was 25. So the median follow-up was 640 days, so it's almost 18 months. And these are the outcomes. So death 5%, specifically cardiac death very low 1%, and target vessel MI 3%. Small proportion of these patients had TLR, so around 6%, and the overall MACE rate was 8%. And we had no documented closure of acute closure of the vessel within 24 hours of the procedure. We just looked at some of these characteristics of patients who were diabetic and non-diabetic, and you could see there were some baseline differences. So, for example, you see more hypertensive patients in diabetes, and of course, previous PCI and CKD were higher in the diabetics group. But when we looked at the clinical outcomes, probably TVMI was higher in the diabetics, but overall other outcomes were similar. And again, we looked at patients who had less than 3 millimeter and more than 3 millimeter treated with MagicTouch. Again, no difference in the clinical characteristics except small vessels were seen in more diabetic patients. And this is again outcome. There was no difference in the clinical endpoints between the two groups. So we can use MagicTouch even in large vessels as well as small vessels. With this, I would like to show some cases which were treated in these centers. So this I would like to take back to 2014 just to say how we have changed our practice. So 2014, I was doing very, very little DCB. So this chap came with angina, 58-year-old, previous PCI to LAD, heavy smoker, COPD, diabetic, renal failure. So this was the angiogram in February 2014. He came back for angioplasty, and I put a stent from mid-LAD all the way to the distal LAD in November 2014. Patient was fine for 2 years, then comes back with angina, and you could see what's happening. The artery started restenosing, the stents, and in 2017, the stents completely blocked off. So no matter what we did, he kept coming back. And unfortunately, in 2023, he has developed severely impaired LV function. He's got ICD in place. He's not doing very well. So let's now come to the 2023, how we have changed our practice. So in 2023, we came across a similar patient, diabetic, and you could see the LAD subtotally occluded here, and it's diffusely deceased. So obviously, we passed the wire, pre-dilated with NC balloon, and this is a post-pre-dilatation. Look how diffusely the artery is deceased. If you want to put a stent, you'll probably use a 2 millimeter stent, which is not ideal. So obviously we used two long DCBs in the mid and distal segment, and proximally we still use stents. So this is a hybrid, classic hybrid approach where stents were deployed in the proximal segment, and this was the final result. Now again, if you look at it, it doesn't look like a stent-like result. There is some improvement in the diameter, but overall, compared to the stented segment, it looks not very good. But we resist the temptation to put more stents or more dilatation. So patient had an angiogram 1 year later, exactly. You could see the problem now. There's a disease in the RCA now, which obviously has a stent, which is blocked off. But look at the LAD. It's grown positively. In fact, if you want to now put a stent, I'm sure you can easily put a 2.5 millimeter stent in that mid-to-distal LAD. And this is just to show you the post-procedure and the follow-up. You can see the difference. The third case, this is interesting because, again, this was done early this year. Heavily calcified LAD, renal failure patient with two complex bifurcation. So if I ask anyone, how would you treat this bifurcation? Everyone says you cannot ignore these bifurcations. You will have to probably place a stent because they're super complex. So, but the problem here was when I tried to wire the second diagonal, I could not wire because the lesion was so tight that the wire doesn't turn. So obviously I wired the first diagonal and I just put a balloon, and I took a picture clearly the second diagonal went down, but patient had no symptoms, no ECG changes. So maybe that diagonal is not that important, but still I didn't want to lose it. So luckily we have these angulated catheters, which are super across, which you can point right at the ostium of the diagonal. And you could see here I've taken a fielded XTA wire and I secured the diagonal. After that, I used 2 DCBs in the diagonal and stented the main vessel. And again, look, this is the final picture. I know there's a linear dissection there in the second diagonal, but TB3 flow. Okay, so I didn't want to intervene. So this was done in 2nd of January 2024, and he had a disease in the other artery, so we brought him back 10 days later, and you could see the patient's completely asymptomatic. The flow is still there, the dissection is still there, but there's no need to do anything for the dissection, and especially the first diagonal looks very nice. So this is the post-procedure, and that's a follow-up. So here we avoided a complex 2-stent strategy in those bifurcations. The last case, this is actually one of the doctors in the hospital who had an inferior MI, is only 45. So obviously we did the angiogram, his RCA was totally blocked with lots of thrombus. So of course we did a thrombus aspiration, established some flow, which resolved the ECG changes and patient became asymptomatic. And we did some NC balloon dilatation. We tend to leave the balloon at least for 30 seconds so that you get less remodeling and of course some ischemic conditioning. So this is the post-POBA. Now, because there was so much thrombus, I was worried that putting a stent might cause slow flow. The second, I may undersize the stent because the artery caliber is probably underestimated in the setting of a STEMI. So obviously we used 2 DCBs here. I tend to use sirolimus balloons for acute MI because of the risk of slow flow from embolization of the particles from paclitaxel. And so this is the final result. So we stopped here. I know it doesn't look like a stent-like result. So patient came back for a check angiogram, and you could see we can't even find where the lesion is. And more importantly, look at the way the artery contracts. It's almost like when we say that the DCBs, like maybe BVS, preserves the arterial anatomy or the vasomotion, you could see the classic example, how the artery contracts so nicely. If I had put a stent, I would have cased the whole vessel. I don't know whether it makes clinical difference, but visually it looks very nice. So that's the follow-up angiogram and the post-procedure. You can see the artery is grown. So clearly the caliber was underestimated if I had put a stent in. So in summary, from our experience with MagicTouch, mostly clinical endpoints are good. Acceptable rates of TLR and MACE despite a complex set of patients we have treated. As you saw, there were 40% diabetics. Results are encouraging, but of course we need more head-to-head clinical outcome comparisons, although we have done angiographic outcome comparisons between the 2 technology. So maybe that is something we should work on. And finally, the aim of DCB angioplasty is to minimize the stent length and to avoid when they are not desired, because we should be avoiding giving such pictures going forward in our practice. Thank you so much.
Thank you very much, and congratulations. Your presentation are always nice. Always.
Thank you so much.
So Sandeep, congratulations. Yes, I have a question for you. I have sometimes problems when I have very tortuous anatomies and side branches with that angulation to navigate with most of DCB that I have in my shelf. Tell me a little bit about MagicTouch in terms of deliverability. I think that's also important when we start to treat more challenge anatomy.
I think you made a very good point, because if you look at the cost, these balloons are at least in the UK, they're 500 pounds. The current stents are 200 pounds or less than that. So if I take a DCB, especially distal RCA, calcified tortuous or circumflex, if I don't put a guide liner or a buddy wire, even with that, sometimes paclitaxels are very difficult to deliver, especially the one we use, which are Prevail or Circumflex. They're very difficult to deliver. Whereas MagicTouch delivers so well. I've not had cases where I could not deliver a MagicTouch, even a 40 millimeter. So in terms of deliverability, it's one of the best ones. So I tend to use those in those kind of lesions.
You agree with that, Antonio? Do you see difference?
Yeah, I mean, unfortunately, paclitaxel are like sand covered, so the particulate makes the friction. Unless you lose the particulate, it's a good way to get it delivered.
Sandeep, beautiful cases and a wonderful presentation. I agree with Antonio, as usual. But we have a great question from Kayvon Karimi here in our audience, who says, how do you treat restenosis post-drug-coated balloons? If a paclitaxel drug-coated balloon was used originally, would you use it again? or use Limus? If so, drug-coated balloon or drug-eluting stent? Does the timing of the original drug-coated balloon angioplasty to restenosis impact your strategy of the type of drug in the drug-coated balloon or the drug-eluting stent? It's a good question.
I think that's a very valid question. The first thing I always ask, which is I've seen in many of my colleagues, when you do a DCB angioplasty in ISR, it's done without imaging. The outcome, no matter what DCB use, they'll come back. They have to correct the mechanical problems. And I have many cases where they come back a month later with restenosis after a DCB. You put an IVUS, you find out either the stents are grossly underexpanded or there is a big calcium chunk behind. No matter what you do, they'll come back. So if they have corrected the mechanical problem and if they do come back, which can happen, I'll probably go with another, like if I use paclitaxel, I use the sirolimus. If I use the sirolimus, I use a paclitaxel. Stenting will be the last choice for me.
But this would be, so restenosis of a drug-coated balloon, how often do you see that? And is there, and so you switch, and what does that morphology look like, and how does it, can you just tell us?
So our data for almost 2 years outcome with ISR is TLR is 17%. It mimics most of the other trials which have been published. So if someone says they get an ISR of TLR of less than 5% at 2 years in ISR, I don't believe that because you have to, because it's the patient's problem, like diabetes, renal failure, it's a new pathology.
Sandeep, the question is DSR, drug-coated balloon restenosis, not ISR.
Not ISR.
Yeah.
Not in-stent. There's no stent here.
Restenosis after DCB for de novo.
DCB.
Oh, for de novo, yes. For de novo, you saw the TLR rates. In our case, it was around 7%. Yes, if it happens with the paclitaxel, I use sirolimus. If it happens with sirolimus, I tend to use paclitaxel. But you see, the good thing about de novo ISR or de novo restenosis is generally it's forgiving with the paclitaxel or a sirolimus because you can put almost stent.
Do you use imaging when they come back with the drug-coated stent restenosis and drug-coated balloon restenosis? Because I think we have to learn about that.
Not necessarily. If this not calcified, I don't use. The only time I use imaging for a de novo lesion is if it's calcified, which needs lesion preparation, not for sizing or anything, because sizing are based purely on angiographic assessment.
Okay.
Okay, thank you very much. We go to Bernardo Cortese, who is going to talk about confidence through evidence, MagicTouch coated balloon clinical programs.
Well, actually, I changed a little bit my topic, but a little bit discussing about the most recent data that we are gathering for a drug-coated balloon so far. So I'm including also some paclitaxel. You may forgive me. And Antonio later will go on more deeply into the analysis of EASTBOURNE and sub-analysis, all of that. So recently, a couple of months ago, we presented this meta-analysis, which for us is very important because it's the first one having compared on the long-term, 3-year follow-up minimum, the several trials, randomized clinical trials of DCB versus drug-eluting stent. It's a investigator-initiated, collaborative patient-level meta-analysis. It's called Andromeda, and we included only randomized clinical trials with de novo. We used, of course, all of the most up-to-date methodology in terms of Prospero, and we also applied to Prisma for doing that. The primary endpoint is MACE, which is hierarchically adjudicated with a landmark analysis at 1 year of follow-up. So these are the trials that we included: Picoletto 2, Bello, Basket, Small 2, Restore, SVD. Actually, we have the data for the first 3 on a patient level, and we will have this one very soon, and we will submit it to TCT this year. This is the primary endpoint of Andromeda meta-analysis. So for the first time, with this population of almost 1,500 patients, drug-coated balloons have shown a reduction in MACE at 3 years in de novo. Small vessels, most of them were below 2.75, some even above for Basket Small 2. But this is, I think, a very interesting finding with a 33% reduction, relative risk reduction of MACE at 3 years, with these curves that tend to diverge quite nicely also on the very long term. These are the determinants of the MACE. You can see that there is a reduction of myocardial infarction, target lesion thrombosis, and target vessel revascularization as well. Then we have very recently accepted the 2-year follow-up of EASTBOURNE study. EASTBOURNE is the largest study done on DCB. It's a prospective investigator-driven registry from Asia and Europe. We have enrolled 2,123 patients. Now we have the 2-year follow-up showing that the late catch-up in terms of events between year 1 and year 2 is quite low, either in the ISR and also in the de novo population. So we have pretty nice results, and it will be published soon in Eurointervention. But now let's come to one of the hottest topics in interventional cardiology so far, which is paclitaxel better than sirolimus, or is sirolimus better than that? So I don't have a definite answer. There are several small studies trying to address this. As Marie-Claude and Antonio were saying, we don't have a direct comparison with a clinical outcome. On a randomized fashion, we have discrepancies. We have bad results for MagicTouch with a Transform-1 study where non-inferiority was not achieved as compared to Sequent Please, but that study, which I was part of, has several flaws with quite a huge number of discrepancies among the centers. So this is why we decided to go a little bit deeper into understanding if there is a difference. So the first one is this late-breaking trial that we presented 2 days ago here. It's a propensity. It's a comparison between two prospective investigator-driven study, not by propensity matching. We applied another methodology. I will go through that very soon. It's EASTBOURNE and PEER with a protégé, paclitaxel-coated balloon, EASTBOURNE with MagicTouch. I will not go too deep into that, but we have the 1-year follow-up, which is showing either in the de novo setting and in the ISR setting no differences in terms of clinical outcome between these two devices. Then, of course, we had to apply a statistical methodology by means of a logistic regression model to reduce the discrepancies in terms of clinical characteristics and procedural characteristics of the two studies. But again, after the final model was applied, there was no differences in terms of clinical performance in ISR and the de novo group of these two registries. And then we have Picoleto 6, which was presented again during EuroPCR a few days ago. Again, not definitive data, but some more evidence. Picoleto 6 is a investigator-driven study trying to address the performance and geographic performance of paclitaxel-coated balloons, several types of them, and sirolimus-coated balloons, several types of them, with a core lab analysis. So we calculated a population of 270 patients with an allocation of 2-to-1 in paclitaxel and in the sirolimus group, with the primary endpoint being late functional loss between the end of PCI and the angiographic follow-up. So it's a novel modality which is taking account, as Aloke was saying, not the late lumen loss, which will, of course, always favor paclitaxel as compared to sirolimus, but of course we have a co-primary endpoint of late lumen loss because here we don't have metal, so we think that it's also another important methodology. If you correctly treat the lesion in expert centers, how is the performance of sirolimus-coated balloon? This is the main goal of this study. So for the calculation of the population, we took the data that we had from Picoleto 2 μFR, where there was a loss, a functional loss at 6 months of minus 0.02. So we applied the non-inferiority margin of 0.06 with a ratio, as I said, 2-to-1. It's not a randomized trial. We calculated a population of 230 lesions to be treated. These are the centers that participated to the study, and these are the devices that have been used. You can see that in the sirolimus group, most of them are MagicTouch, but we also have a good number of solution. And in the paclitaxel group, most of them are Sequent Please, but we also have Elutax and Prevail. This is the QCA result of Piccoletto 6. You can see, very interesting. It is a small vessel disease study, 2.2 by core lab analysis. We have a lesion length which is more than double than Transform 1, is 23.7 millimeters. So it's many patients had a diffuse disease. At post-PCI, there is a acute performance of paclitaxel, of course, by chance, which is a little bit better in terms of percent diameter stenosis, and this is the late lumen loss, which is minus 0.02. It's a negative late lumen loss, not surprisingly, in the paclitaxel group, but it's 0.12 in the sirolimus group, which is quite similar to our first experience with MagicTouch, with a Fasico-native study where it was 0.09. Interesting, lumen enlargement. We have some lumen enlargement also with sirolimus. We have it more with paclitaxel because of the effect of this drug into the media. It is, in this study, 55% of lumen enlargement in 55% of the patients, but we also have it in 39% of the Sirolimus-coated balloon patients. I have to tell you that also POBA can exert... Yeah, I'm still on time, I think. I'm going to finish, yeah. So also POBA can exert some lumen enlargement in 10 to 15% of the cases. This is just as an important information. So let's come to the primary endpoint of the study, which is late functional loss. Late functional loss is the difference between functional assessment at the end of PCI and during angiographic follow-up. And you can see here that it is 0 in paclitaxel and 0.03. So there is no significant difference because also sirolimus did stay into the non-inferiority margins as compared to paclitaxel. Then my last two slides are on the ongoing trial with MagicTouch. This is Transform 2. It's one of the two big trials that will try to change the landscape of treatment of coronary disease patients, comparing a device, here MagicTouch in the solution versus drug-eluting stent. We are recently, we will very soon open also Brazil, so this will be a really worldwide study. We are including native vessel disease patients between 2 and 3.5 millimeters, lesion length up to 50. We will prepare the lesion. If lesion preparation is okay, according to the expertise of the centers, so good flow, person stenosis, maximum 30%, we will randomize patients. We randomize patients to MagicTouch or Science. And the primary endpoint is TLF, where we expect the non-inferiority at 1 year of MagicTouch as compared to Science, and we are also expecting the superiority in terms of NACE. That's it. Thank you for your attention.
Thank you. I think we have time. Thank you very much, Bernardo. We have time for a couple of questions.
There is a question here from an anonymous person who says, would you expect the same result as in Andromeda for larger vessels greater than 3 millimeters?
I think so. I don't expect particular problems if we apply a good technical preparation and we just deliver the drug, which is the way as a DCB should be used in the end. So we don't leave a flow limiting dissection. We don't have a high recoil. So why not? I'm sure. And we are using DCB also in larger vessels, and we are not having problems. So yes, my answer is yes.
So far in Transform 1, how many patients were not enrolled because of some dissection and went over to stenting from the very beginning? Do you have the number?
In Transform 1? No.
No, in Transform 2, sorry.
In Transform 2, yeah, there is a nested registry. We are including that. We have so far 300 and something patients. 330
but
patients.
how many patients did not enter the study?
Now we have enrolled 900 patients. So 300 out of 900. So it's 25%.
25%.
Yeah.
So it's
Dissections can be left untreated.
Well, first of all, dissection is good. We have seen that. There is a very nice study by the group of Yamamoto. Well, actually, they did two studies, one with angiographic parameters, another one with OCT parameters, showing that if you dissect, at least mostly with paclitaxel, the drug is entering the wall nicely. So what type of dissection can you leave? Type A, type B, sometimes type C. What is important is that you have a good lumen and you have a fast flow. TRIMI3 fast. Less than that, stent.
Okay, there is a final question there.
Yeah, we are using scoring balloon actually in the last few 6 to 9 months, cutting balloon again when you are able to deliver it, of course. And then for fibrotic lesions, moderately calcific lesions, they are working well, but we don't have data.
Okay, thank you very much. We go to the next presenter, Antonio Mangieri.
We have already seen by Bernardo that we have a big clinical program related to the EASTBOURNE, which is the biggest available registry and experience in a real world using the Sirolimus-coated balloon in all-comers population, both with the ISR but also coming for de novo lesion. And we have done a lot of subclinical studies focusing on different scenarios, and I will show you which type of results we have obtained during this type of research. I think that this one is under evaluation on CCI. I think it's a quite interesting sub-analysis of the EASTBOURNE because for one of the first time we evaluated the safety of giving a single antiplatelet therapy to these patients treated with the Sirolimus-coated balloon. You see that the minority of the patient, of course, was treated just with a single antiplatelet therapy after a loading dose, and most of the patients were, of course, treated with the DAPT. These are the outcomes at 1 year follow-up, and you see that essentially we did not observe any sign of problem. We had no evidence of acute occlusion of the vessel. We had no evidence of urgent or fast revascularization during the first hours after the procedure. So it means that no acute occlusion occurred, and maybe with a single antiplatelet therapy we are safe enough to treat the vessel using DCB. Of course, if you look at the all-cause data at 1 year follow-up, you see that there is a big difference between the two groups, but I think it's related to the general features of the population, because patients, of course, with the single antiplatelet therapy were sicker compared to the one treated with the DAPT. But in general, I think that we are always scared, and we are treating a lot of sicker patients with the passing of time. Take, for example, this case of an 80 years old. He had an active colon cancer. He came with non-STEMI and the evidence of moderate to severe anemization. You see there is a diffuse disease with involvement of the first margin, but of course also of the LAD. So the patient was treated. I think in this case we planned an hybrid revascularization, putting a short stent, as also demonstrated by Sandeep previously, and you can see that at the distal edge of the stent we left one linear dissection, but with good flow up to the distal part of the LAD. This dissection was treated with the MagicTouch Sirolimus-coated balloon, and at the same time so we applied also the Sirolimus-coated balloon on this obtuse marginal, just to minimize the amount of stent that we want to implant in this patient because of the risk related to the long dual antiplatelet therapy. The patient came 6 months after for an angiographic follow-up, and you see that there was a patency, of course, of the stent placed in the proximal segment of the LAD. We also dilated the diagonal, and you see that there is still a dissection, but the flow is good, and you see that essentially we observed a nice sealing of the mid-distal portion of the LAD with a perfect distal flow. Also, the situation, let's say, on the obtuse marginal is good, and so this patient was safely treated. We gave a very short DAPT just related to the presence of the proximal stent on the LAD, and in this case I think that an hybrid strategy can favor the shortage of the DAPT in these complex patients. Another problem that has been already discussed by Sandeep is the presence of diabetic patients in our population. We know that the performance of DS is very poor in this subsetting, and for example, taking into account some data coming for the sugar trial, which compared in diabetic patient the performance of the CREATE compared to the Resolute tonics, you see that at 1 year follow-up, there is a high recurrence of the event in this population with a with a progressive growth of events across the year. And we have also the 2 years follow-up, which confirm this finding. So diabetic patients have a very poor response to DS. We compared in the EASTBOURNE the two type of population that we had inside, so diabetic versus non-diabetic patients. And again, we confirmed that the performance of the Sirolimus-coated balloon is good in both the situations, so in presence of diabetes and in absence of diabetes, with comparable outcomes both in the novel lesion but also in ISR. Of course, these data are very preliminary, are retrospectively taken, and these are essentially post-hoc analysis, because in most of the cases these patients were treated in small vessels, so the clinical events related to the follow-up were very short. So, but my consideration in diabetic is that their prognosis is poor. We have demonstrated some efficacy of the Sirolimus-coated balloon, and our aim in this particular type of population is to reduce and to minimize the stent length. So I think that in this population, a DCB full strategy or an hybrid solution can help us to minimize the number of events. Take, for example, this case that I did a couple of months ago. We have a diffusely diseased RCA with some stenosis, especially in the first part of the vessel. It seems to be quite calcified, but especially fibrotic. We planned to do a revascularization based on PDPA, so a live tracing of the, let's say, distal pressure that we have in the vessel. So you see that we pre-dilated the vessel. There is still some stenosis before the cracks with a poor PDPA distally. We went up with the treatment using a non-compliant balloon to better have preparation of the vessel, and finally you see that the result is excellent with a short stent applied just in the proximal part of the RCA with good flow, a good luminal gain at the end of the procedure. Again, I believe that in these patients implanting too much stent is a bit of fashion, and the revascularization using DCB can be very useful. This is a case done by Professor Colombo, I think a few months ago. This is by a diabetic patient with a severely calcified LAD. You see with an island of maybe good tissue in the mid portion of the LAD. The lesion was nicely prepared using a rotational atherectomy, and then we went with a non-compliant balloon, and finally we applied 3 DCB all the way up, you see, from the distal part up to the proximal portion. And you see on the left side the final result with some dissections, but they are linear dissection with good flow distal, and you see at 5 months follow-up the nice result with the vessel growth, also using the Sirolimus-coated balloon. Finally, I think also two-stent strategy in bifurcation have very poor outcome. We observed in the EASTBOURNE sub-study in bifurcation a very good outcome of the bifurcation treated with use of Sirolimus-coated balloon, both for the main branch and side branch, but also for only the side branch. And again, I think that in this type of scenario, use of DCB can allows us to perform a simpler procedure, a faster procedure, and a quicker procedure. This is a case I've done a few days ago. A patient coming for unstable angina. I just decided to pre-dilate the LAD and also the diagonal, applied a regular stent in the proximal LAD. I did the DCB on the diagonal on the distal portion of the LAD, and you see that the result is pretty nice. So finally, we have created some more evidence. For the first time, we have established that maybe the safety of the single antiplatelet therapy in a patient treated with Sirolimus-coated balloon in diabetic in bifurcation. We have demonstrated a good outcome and the feasibility of a DCB-based strategy, but these numbers are small, and of course we need more evidence coming from randomized trial. Thank you.
Thank you. Thank you very much, Antonio. Alex, you have a question?
Yeah. I have a question for both Antonios regarding physiology. So in the beginning, I used to use a little bit more physiology because when I saw some residual dissections, residual stenosis, particularly for side branch. But now I'm more relaxed. What about you? Do you recommend, and when do you recommend using physiology versus imaging, for instance, versus IVUS and OCT?
Yeah, this is a very good question. I think that finally, when you have a very diffuse disease and you have this run pattern at the FFR or PDPA evaluation, I think maybe you can go just by an angiographic evaluation. If you have to treat a more focused disease and you want to make sure that you achieve a very good result, so both in terms of angiographic result, but also in terms of physiology, I think that the guidance with the FFR is better. But I think that, Prof, maybe we are changing a bit our strategy and we are more prone to be guided by the angio only.
I use physiology when I treat diffuse disease, really long lesion. And one data that we didn't publish, but I really pay a lot of attention, is how behaves the PDPA. After, at the end of pre-dilatation, PDPA can be 87, 89. If after 1 minute is 92, 93, 95, that's good. If after 1 minute is 84, 83, that's bad. So this is not the absolute number, but what happened after 1 minute, 2 minutes. No, I don't wait 5 minutes, 2, 3 minutes.
Yeah, I mean, I think what I'm seeing here is pretty amazing, the result of that case with the diabetes and the vessel growing. I mean, I have to say, I have not been a fan of the techniques you've been using, Antonio, but these examples keep coming back and back. And now you use imaging, is that correct? You want to just tell everybody how, like, what made you leave all those dissections behind and not be worried about vessel closure when we've all been, you know, absolutely horrified by the vessel closures in those early days of POBA?
But, you know, I use imaging also to learn myself. If I see a dissection that angiographically I don't like, and PDPA is 95, which is good, I still do imaging, and what I see, and we go back at the time of spot stenting, I see that the lumen is large, and the dissection lumen is not small, but the true lumen is very large. So it's like a football game between 10 players and 3 players. The small players is still 3, but they're not going to win against 10 players.
Yeah.
It depends if they're Brazilian.
All right. Any questions from the floor? Okay.
Should we move to you?
Yeah.
Our last presenter, Roxana Meran, and she's going to talk about diabetes and the challenges and the future opportunities.
Yeah, I think this last presentation told us that, you know, there isn't a single answer for everything, and that diabetic patients do have diffuse small vessel, diffuse disease, and I think it's very, very important to kind of talk a little bit about. I mean, I'm going to talk to you about diabetes, the global diabetes. Ability diabetes study that we just did, but more importantly about this global epidemic of diabetes and where we're going with it. It is growing in every part of the world, not just in the United States, but in every part of the world. If you look across, there are in Africa 156% increase, 62% increase in South and Central America. In the world, about a 50% increase, and I think we're expecting it to just continue to grow unless we get our arms around it. And the outcomes of diabetic patients are not great. This is the REACH registry of International Prospective Registry of patients with high risk of atherothrombosis, established atherothrombosis. Look at the diabetic patients in the gray bars, and this is if they had the overall rates of about incidence of hospitalizations just for heart failure, let's say, 10%, 11%, 13%, just a tremendous amount of And diabetes is what's driving these important events. And if you look at death at any cause or acute myocardial infarction, that glycosylated hemoglobin actually could predict it. So when you go to the doctor and the doctor gets you the hemoglobin A1C and you start to see the numbers growing, well, this is what's happening to the curve. Hopefully it's not your numbers growing, but when you see your patient's hemoglobin A1C go from 5.6 to 6.3 and then to 7.3, you can tell him or her that their chances of dying and having an acute myocardial infarction is on the increase, and that it will increase over time. And you see how it really takes off once you get above a certain amount. Luckily, there have been a lot of great drugs, and we have to think beyond intervention to prevention for our patients. This stents and drug-coated balloons will do nothing if we are not taking care of the entire systemic treatment of these patients. And now we have great choices like GLP-1 agonists and SGLT2 antagonists, both really, really incredibly effective also in diabetic patients with chronic kidney disease. But when we look at our databases, even from the time that they've been made available, their usage is at less than 10%. In most of our patients, it's about 5% usage. It's difficult to get them. They're incredibly expensive. They're being used for weight loss rather than for diabetes treatment. And we understand that despite all of this, access to these very, very fantastic drugs have not yet been made available to the worldwide population, and hence the adverse cardiovascular events and coronary revascularizations continue to grow. When we look at revascularization in terms of what we're doing with our stents, Freedom was with the first generation drug-eluting stents, but you could see just forget about revascularization. We know that the first generation drug-eluting stents are worse for revascularization, but death, MI, and stroke at 1 year was at 10% for diabetic patients with multivessel disease. And these outcomes, when you see, are mostly driven by diabetes. It's really the diabetic patients who are doing worse with our revascularization, especially with multivessel disease. And we also have data from the pooled analysis of left main CAD, and diabetes is associated with higher rates of death and MACE all through 5 years. And these rates are not small. We're seeing revascularization of about 9 after revascularization, cumulative incidence of TLR of about 10%, 1 to 5 years going up and continuing to build on that a huge number. There's no question when we're thinking about CABG favoring over PCI, it's almost always in diabetic patients, and we really do want to avoid that. We saw the cases that Antonio just showed, Antonio M. just showed with diffuse disease. Those are not great runoffs for CABG, and so I believe that we're looking at a future that combines perhaps drug-eluting stent technology with drug-coated balloons. Where are we with drug-eluting stents? The stent technology has come a long way, the new generation drug-eluting stents, but the data from everolimus-eluting stents versus the paclitaxel-eluting stents, this is old data, 10% rate of death, MI, and TLR at 1 or 2 years, and you could see that the meta-analysis of all of these with the biodegradable DES and anti-proliferative drugs, they failed to show superiority, and we saw that there is a tremendous issue with regard to the suboptimal outcomes of PCI in diabetic patients, and so we think about all of these other things that are happening, the vasculopathy, chronic kidney disease, altered antiplatelet issues, and myocardial dysfunction, and exogenous insulin. The limitations are there for the drug-eluting stents, and perhaps there's more than just beyond the lesion because there's so much more, and that idea of combining perhaps DES with drug-coated balloons is going to be the promise of the future. Do we have any therapeutic options for diabetic patients undergoing PCI? I think the novel perspective of not leaving anything behind is very exciting. And I think this is about that EASTBOURNE diabetes data that you just saw. And I think when you see that in the diabetic, obviously it's small numbers of patients, but still, it is very, very interesting in the per patient analysis. And then, of course, is it possible to have a single device? And that was the idea of the Abluminous DES. We came up with, we had the fortune of working and coming up with, working with Concept Medical in terms of this novel device, Abluminous DES, thin strut, cobalt chromium, sirolimus-eluting platform, designed almost for diabetic patients because of the fact that there's abluminal coating, but the drug, which is sirolimus, and the implantation technique that requires 45 seconds because the balloon is sprayed, the device is crimped on the balloon, and then the drug sprayed over the balloon and the stent with a homogeneous delivery of the drug, also at the edges, but requiring about 45 seconds to allow that complete drug delivery with the scaffold being placed in place. We designed this study to show not only that it would do as well as the best-in-class Xion stent in over 3,000 patients, all-inclusive diabetic patients, 1 to 2 vessel disease, stable or unstable patients. We excluded STEMI and PCI for ISR or any grafted lesion, and basically had 74 sites, 16 countries. And one of the unfortunate things was that we did this during the COVID pandemic, and we had amazing sites with great work that they did in enrolling these patients and bringing them back, at least trying to get in touch with them for follow-up, which was not easy. We had 2 co-primary endpoints of TLR, as well as target lesion failure. We had designed it for non-inferiority for TLR against Xience, but the event rate was assumed based on all of the data that we had at 7.5% for everolimus-eluting stents in previous prospective randomized trials that we had seen, and with a non-inferiority margin of 2.8, and for the target lesion failure, we thought about 9% with a non-inferiority difference of 3%. We had an amazing partnership with Circ and Mount Sinai in overseeing these data. Our 3 co-PIs were Sansei Saito, Professor Colombo, and Professor Abajide, and an incredible executive committee, an independent blinded CEC, and then a reevaluation with an external CEC as well for harmonization of the work, as well as the Data Safety Monitoring Board chaired by Deepak Bhatt. The trial did extremely well. We enrolled in these countries large numbers of patients, about 400 in Brazil, 200 in Bangladesh, and you see our top enrolling nations. We enrolled finally and randomized 3,034 patients with excellent follow-up, about 97-98% follow-up, and the patients were the usual patients we see in the hospital for diabetes, referred for PCI. Now, most of these are a lower syntax score, as you will see, but 29% women, we usually don't get that. Age 67, ACS in about 26%, prior PCI 22%. The glycosylated, the hemoglobin A1C was 8%. And mostly radial access. You see the syntax score was 12, so these were simple diabetic patients, but 26% had multivessel disease, total stent length of about 41 and 1.7 stents per patient. The target lesion revascularization for one of the co-primary endpoints, which was a non-inferiority hypothesis, was pretty low.
We need
I know, but do you want me to stop? I know pretty low. We missed the non-inferiority, but take a look at this, 5% for Abluminous, but unheard of 2% for Xience. We had assumed a 7.5%. And when you see this, we miss non-inferiority, but you need to understand that this does not mean inferiority because of the fact exactly very similar to the bicuspid aortic stenosis valve case that was presented yesterday. These becomes unfortunately inconclusive, and we have to wait for the 2-year follow-up. And let me just go and show you that one of the things was the fact that we were assumed a 7.5% for control and received a 2.2% for the control arm makes this inconclusive. But basically, the main message is that both these stents did extremely well, 5% and 2.5%. We are waiting for the 2-year follow-up, which we believe will be extremely important, and plan to bring it right back here at EuroPCR next year to present it to you to prove the non-inferiority of these two devices. Thank you so much for your attention.
Thank you very much. Sorry, Roxana, if I had to give you. So I think we have no time, but I think the conclusions are obvious. Drug-eluting stent is going down, drug-coated balloon is going up.